Thank you so much for inviting me to this 11th International Neonatology Conference in the Emirates. First of all, I'd like to thank my good friends Junaid Khan and Aiman Rahmani for inviting me. I have so many good memories from your meetings, and I really wish that we all could have been together. Hopefully, next time that will be possible. So this lecture is about oxygenation of the newborn. And here are my disclosures. And I also put 4 learning objectives for this lecture. First of all, it's to understand the normal development of oxygen saturation the first 5 to 10 minutes of life. And secondly, why the saturation should reach 80 to 85% within 5 minutes in premature infants. And I also would like you to understand the dilemmas of oxygen therapy in the newborn period, especially in the delivery room, and also future challenges and research topics, because there are so many research topics we need to go into the next years to come. So let's start with some historical remarks. Oxygen was described as an element in 1772, and already a few years later it was used in newborn care. For almost or more than 200 years, pure oxygen was used, for instance, during gestation, especially after 1928. However, in the 1990s, 2 studies were published, the RESER 1 and RESER 2, showing that it is possible to resuscitate term and near-term infants with air just as well as with oxygen. And some years later, the first meta-analysis on this topic were published, showing that yes, it is possible to resuscitate with air, and in fact, the outcome is better with air compared with 100% oxygen. So in 2010, ILCOR changed their guidelines from oxygen to air, and I'll come back to that in a minute. At the same year, the first oxygen saturation nomograms were published, showing that oxygen saturation is low immediately after birth and then gradually increases during the first minutes after birth. So the world map regarding newborn resuscitation before 1998 looked something like this. All guidelines recommended the use of 100% oxygen. And those babies who were ventilated at that time, they got this enormous PO2 peak, which we today know may be toxic. So in 2008, we published this meta-analysis where we summarized the results from 10 studies, including more than 2,000 infants who had been randomized or pseudo-randomized to either air or 100% oxygen in the delivery room. And what we found was that there is approximately 30% reduction in mortality in those who received air compared with 100% oxygen. So consequently, ILCOR changed their guidelines in 2010, stated that in term infants receiving resuscitation at birth with positive pressure ventilation, it is best to begin with air rather than 100% oxygen. So the world map changed and looked something like this. And now babies who were resuscitated had this more physiological normalization of PO2. We avoided this enormous PO2 peak, as I showed you. So resuscitation with air reduces mortality probably because of less oxygen toxicity. And it also opened up for the introduction of new resuscitation programs applying air instead of 100% oxygen, as for instance the Helping Babies Breathe program. But there was and still is practice without evidence regarding, for instance, premature infants. We don't know the optimal initial FiO2, and we don't know the optimal way to titrate FiO2 versus saturation to achieve the optimal saturation the first minutes of life. So what about preterm infants? Well, in 2010, ILCOR stated that because many preterm babies less than 32 weeks gestation will not reach target saturations in air, blended oxygen and air may be given judiciously and ideally guided by pulse oximetry. And in 2020, they specified this more and stated that one should start with 21 to 30% oxygen for all preterm infants less than 35 weeks. Now, the European consensus guidelines on RDS, published in 2019, says that oxygen should be controlled by using a blender and that an initial FiO2 of 30% is appropriate for babies less than 28 weeks gestation, and 21 to 30% for those between 28 to 31 weeks, and adjustments should be guided by pulse oximetry. What about moderate and late preterm infants? Well, we very recently published a survey of clinical practice in 20 countries, and this was quite recent data. We collected answers between October 2020 and March 2021, and we got almost 700 respondents from high and middle income countries. So these are babies between 32 and 36 weeks. And here we have the countries who answered. You see that from the Gulf area, Oman participated in this study. So the first question was availability of oxygen blenders in the delivery room and operating theater. And you can see that it was not a big difference between high and middle income countries. Approximately 70% or 2/3 at least had these blenders. What about pulse oximetry? Again, it was no big difference between high and middle income countries. Approximately 90% have access to pulse oximetry in the delivery room and operating theater. And most of those the big majority of those who replied said that they start with either room air or 30% oxygen. Only 5 and 2% start with 100% oxygen, probably because they don't have blenders, I guess. An important question is how saturation should develop optimally. And this is an article I published now 15 years ago in Journal of Pediatrics, where I put together a number of studies in this field. And you see that oxygen saturation starts low here at 1-2 minutes and increases gradually, and took approximately, according to these data, approximately 4 minutes to reach a saturation of 80%. But then some years later, the so-called Dawson curves were published, where Jennifer Dawson and co-workers, they had collected data from a number of babies with different gestation ages. And here you can see how the saturation develops in babies 37 weeks and above. And here is the 50th percentile, and you see there's enormous variation between the 3rd percentile down here and the 97th percentile up here. But you also see that at 1 minute, most of the babies start low and then gradually increases. So according to these data, it takes 2.5 minutes to reach a saturation of 80%. And for all babies, it took 3 minutes. Between 32 and 36 weeks, it takes 3.2 minutes to reach a saturation of 80%. And for those less than 32 weeks, according to these curves, it takes in median 3.6 minutes to reach a saturation of 80%. Now, those data were published before late clamping was practiced. And this is a study from Nepal by Kisi and co-workers showing that if you practice late cord clamping, you see that the saturation is higher already at 1 minute of age. And this seems to be the case for the first 5 to 10 minutes after birth. And also a study from Spain, from Max Vento's group, shows the same. This is a very recent study. And this is compared with the Dawson nomograms. And what you see here is that if you practice delayed cord clamping, instead of 2.5 minutes, it takes 1.1 minute to reach a saturation of 80%. And Max Vento and his group, they have also shown that the saturation is dependent on whether the baby is on CPAP or not. So if the baby is on CPAP, the saturation increases faster, the green line here, compared with the Dawson data. And also a sex difference, girls reaches a saturation of 80% earlier than boys, 4.8 minutes versus 5.7 minutes. So there's a number of factors that seems to influence how the saturation increases. So what about the very low birth weight infants and the immature infants? Should we ventilate these babies with an initial high or a low FiO2? Well, we have carried out several meta-analyses in this field, and I will show you data from one of these where we compared outcome in babies less than 32 weeks who had been either resuscitated in the delivery room with a high FiO2, 60 to 100% oxygen, versus a low FiO2, 21 to 30% oxygen. So this is data many of you have seen before, but regarding the primary outcome, hospital death, there was absolutely no difference whether you start high or low. And also for secondary outcomes as BPD, severe intraventricular hemorrhage, severe ROP, necrotizing enterocolitis, or PDA, there was no difference whether you start high or low in the delivery room in these babies. And then in 2007, the so-called torpedo trial was published with a principal investigator, Julie Owe from Sydney. In this study, infants less than 32 weeks were randomized to receive air or 100% oxygen if they needed positive pressure ventilation in the delivery room. And we didn't find any difference in mortality when we looked at all babies. However, when we analyzed specifically results from babies less than 28 weeks, we found that those who had been started with air had a significantly higher mortality than those who had been started with 100% oxygen. Relative risk 3.9, as you can see here. And we also found that those babies who had reached a saturation of 80% or more within 5 minutes, they had a 50% reduction in primary outcome, which was death or disability, compared to those who did not reach a saturation of 80% within 5 minutes. And those babies who didn't reach a saturation of 80% also had more severe intraventricular hemorrhage compared to those who reached a saturation of 85%. And when we did a follow-up of these babies 2 years later, we saw that the cognitive score was significantly higher in those who had reached a saturation of 80%. It's 5 points higher. This is how babies in OI's cohort, this is not only from the torpedo trial, it's actually from more than 700 babies she and her cohorts have followed. And here you see babies less than 29 weeks were started with an FiO2 of 0.3. They start here low, with approximately a little bit above 50%, but you see this gradual increase in saturation. And these babies, they need 6 minutes to reach in median or in mean to reach a saturation of 80%. So it indicates that maybe it's a little bit too slow. So if you start with 90 to 100% oxygen, yeah, then it takes in mean 3.6 minutes to reach a saturation of 80%. So here I compared 30% versus 90 to 100% oxygen, and you see that those who receive 90 to 100%, they have a higher saturation, which is not surprising. So the question is then, should we start with a low FiO2 and titrate up? Or should we start with a high FiO2 titrate down if it's needed? It seems that immature infants, at least immature rabbits, they need some extra oxygen in order to open the glottis. And without an open glottis, it's not possible to ventilate these babies. So perhaps the most immature babies would need a dash of oxygen. If that is the case, this should be as low and brief as possible, but we don't know what is the optimal. But in order to answer this question, Dekker and co-workers from the Netherlands, they randomized babies 29 weeks or less to receive either 30% oxygen or 100% oxygen. And here they had a system where they titrated FiO2 according to the saturation. So what I found was that if you initiate stabilization of preterm infants at birth with 100% oxygen, they had a higher minute volume, they had an improved oxygenation, and a shorter duration of mask ventilation as compared to 30% oxygen, without increasing the risk for hyperoxia or oxidative stress. So this is, of course, very promising, but I think it's important to underline that this is a very small study, totally only 44 infants. And we have almost 1,000 babies in our cohort. Here I have shown how the saturation develops in this Dekker cohort. So here, the orange here is babies started with 30% oxygen. You see they start lower than 40% saturation. And here, babies started with 100% oxygen. They start a little bit above 50%. So for these babies started with 100% oxygen, it takes 4 minutes to reach saturation of 80%. And for those who started with 30% oxygen, it takes between 5 and 6 minutes. So again, this indicates that maybe these babies need a little bit more than 30% oxygen. So what I've done now is that I'm comparing the development of the saturation in the OA babies to 9 weeks or less. So here's 30%. And what you see that is that the Dekker baby, they start much lower than the OA baby, in spite of the fact that both start with 30% oxygen. So the Dekker baby, they need 5 minutes to catch up with the OA babies. And here I have compared the OE baby, the red here, with the DECA babies who received 90 to 100% oxygen. Again, the DECA baby, they starts much slower, and it takes 4 minutes to catch up with the OE babies. So here I put all the 4 curves together, and I think this indicates and perhaps tells us that more important than starting with a high FiO2 is how you titrate the FiO2 according to saturation. Because we want to start as low as possible. We don't want to start with 100% oxygen if it's not absolutely needed, because we know that this may trigger adverse effects. Well, so maybe 30% is not optimal for these babies, maybe 40% or 60% oxygen. And this we want to test out in a new study, Torpedo 3060. And I'm sure that if any one of you want to join that, you can contact, for instance, Rebecca Brown or me. And then I want to talk about the impact of the heart rate and the saturation. We very recently published this study, the so-called Preterm study, where we were data from 700 babies less than 32 weeks. And we looked at outcome in babies who had no bradycardia, defined as a heart rate above 100 or above the first 10 minutes of life, versus transient bradycardia, heart rate below 100 beats per minute for less than 2 minutes, or prolonged bradycardia, heart rate below 100 beats per minute for 2 minutes or more. So here we have some infant characteristics, and you see babies gestation age typical 27 weeks, and birth weight less than 1,000 grams in mean. So what we found here was that mortality seems to increase with increasing duration of bradycardia, which probably is not so surprising. So, and here we have carried out the meta-analysis of the studies we have combined in this Preterm analysis, and you see that if you have prolonged bradycardia, mortality increase odds ratio is 3.49. This is highly significant. So here we have compared the effect of bradycardia with a satisfactory development of saturation versus a reference group, those who had no bradycardia and had a saturation of 80% within 5 minutes. So what you see here, a prolonged bradycardia, even if the saturation develops satisfactorily, increases risk for mortality odds ratio here 10.2. However, if the saturation is less than 80% at 5 minutes, transient bradycardia increases risk of mortality 8.2 times, and the combination of prolonged bradycardia and a low saturation the first 5 minutes increases the odds ratio almost 20-fold, odds ratio 18.6. So this tells us that the combination of low saturation and bradycardia is not a good sign for outcome. So what should we do? Well, we should target saturation of 80% within 5 minutes. We are quite sure that supplemental oxygen is needed in most immature infants, less than 28 weeks gestation. But if they need oxygen, it should in case be given as low and brief as possible. It is important to avoid bradycardia, and the combination of bradycardia and not reaching saturation target of 80% within 5 minutes increases mortality. So I'd like to underline that if you use supplemental oxygen, even very brief, this may lead to increased oxidative stress, inflammation, genomic changes, reduced DNA repair, cell growth inhibition, and long-term effects may also induce epigenetic changes, as we're shown in animal studies. So what we recommend, but I don't say that we know the final answer, but we recommend so far that we should start low, for instance with 30% oxygen, and titrate up according to the saturation and the clinical response, which should be heart rate, and reach the target for saturation and the heart rate within 5 minutes. And then I'd just like to close with showing some very interesting data recently published in July by a Finnish group, Rantakari and coworkers. They had saturation values and arterial blood gases and FiO2 from 73 Elgins, gestation age in mean 26 weeks. And they followed them the first 3 postnatal days. And they looked at white matter injury by MRI and cortical injury by so-called magnetoencephalography. And what they found was that those babies who had a white matter injury, they had more often a saturation less than 90%. And fewer of the babies had a saturation above 98%. However, for those babies who had a cortical injury, it was the opposite. They had less babies with a saturation of 90% and more babies with a saturation of more than 98%. So one conclusion from this study is that lower saturation Q2 levels and higher FiO2 need during the first 3 days of life in these small babies are associated with later white matter abnormalities and adverse neurodevelopment. I didn't show you those data. Infants with abnormal cortical function have higher early saturation and Q2 levels than the infants with more favorable cortical outcomes. So these results indicate that brain structures, white matter, are more vulnerable to hypoxia, whereas others, such as cortical areas, are more sensitive to hyperoxia. Well, of course, these data have to be confirmed in other studies, but they emphasize the importance of maintaining strict saturation targets during the early postnatal period. And it also makes this field much more complicated because it may indicate that some areas of the brain need a higher saturation and other areas would need a lower saturation. Makes it much more complicated in the future. So what should we do in the delivery room? Well, between 29 and 34 weeks, start with 21 to 30% oxygen. Babies 28 weeks or less, we think we should start with at least 30% oxygen. And here are some the nomograms you can follow and reach a saturation of 80 to 85% within 5 minutes. Well, if you need chest compression, I didn't have time to go into that. We still recommend to start with 100% oxygen. But as soon as you have established circulation, wean quickly to 21% oxygen, especially in term babies without lung disease. Here are some references for those who are interested. I would like to thank my distinguished collaborators, Max Vento, Satyan Laxmin Rushma, Julie Owie, and Vishal Kapadia. Thank you so much for your attention.